Let's dive straight into Step 2 CK, lower GI, and anorectal emergencies. In this explainer, we're breaking down the exact clinical decision pathways you need for the wards, focusing purely on rapid vignette recognition and your next best steps.
Section 1. The acute abdomen and rectal complaint split.
When you're on the wards or facing a tough question, your first critical move is splitting that differential. You've got to instantly recognize an acute abdomen. Look out for toxic-appearing colitis with systemic toxicity, painless distension in a hospitalized older adult, or the abrupt onset of a volvulus. Those require rapid, systemic management. Contrast that immediately with localized findings, right? Things like rectal urgency after receptive anal exposure, protruding tissue, or sharp pain with defecation.
Section 2. Colonic dilation and toxic megacolon.
So, picture a patient presenting with severe colonic smooth muscle paralysis. You grab an abdominal X-ray, and boom, it shows colonic dilation over 6 centimeters. But the real key here is the clinical picture. We're talking fever, tachycardia, hypotension, leukocytosis, anemia, and distinct abdominal tenderness. This systemic toxicity is triggered by a severe underlying inflammatory state. Classically, you'll see this with an ulcerative colitis or Crohn's disease flare, or maybe a severe infectious colitis like C. diff.
Immediate management is absolutely crucial here. You want to initiate bowel rest, aggressive IV fluids, and broad-spectrum antibiotics right away. If it's associated with IBD, get those IV steroids going. But honestly, it's just as important to know what you strictly avoid. Stay far away from anti-motility agents, opioids, anticholinergics, and absolutely no colonoscopy. Doing any of that carries a massive risk of toxic perforation. You're moving to urgent surgery if you see perforation, peritonitis, massive hemorrhage, or if medical therapy just flat out fails.
Now contrast that highly toxic state directly with Ogilvie syndrome, which is an acute colonic pseudo-obstruction. You're still going to see massive colonic dilation, but the mechanism here is autonomic dysregulation without a mechanical obstruction. This classically pops up in hospitalized older adults after a major surgery, trauma, or maybe due to a severe electrolyte disturbance. Your initial treatment is conservative. Bowel rest, fix the electrolytes, stop offending drugs like opioids, and get them ambulating. If it's severe or persistent, your specific medical go-to is neostigmine.
Moving on to Section 3, volvulus and microscopic colitis.
Notice the stark radiographic differences between the two main types of volvulus here. On the left, you can clearly see the closed-loop obstruction and dilated cecum of a cecal volvulus. But on the right, look at that classic inverted U-shaped loop. That's the famous coffee bean sign, and it's the absolute hallmark of a sigmoid volvulus.
You've got to tailor your management based on demographics and what you see on imaging. An older patient with a sigmoidal volvulus, assuming they're stable and don't have peritonitis, gets endoscopic detorsion via flexible sigmoidoscopy first. However, a younger patient with a cecal volvulus, they require an emergency laparotomy right out of the gate because endoscopic decompression is simply less effective and the risk of ischemia is way too high.
Let's pivot to a completely different presentation. We're talking chronic, watery, non-bloody diarrhea, classically in an older woman. If you do a colonoscopy and it looks completely normal, but the biopsies come back showing lymphocytic or collagenous infiltration in the lamina propria, you're dealing with microscopic colitis. First step, stop their NSAIDs, PPIs, SSRIs, or smoking, and start antidiarrheals. If the disease is being stubborn and persists, your targeted treatment is budesonide.
Section 4, proctitis and anorectal structural disease. Always separate radiation proctitis by its timeline. Acute radiation proctitis happens within 8 weeks of exposure. It causes direct mucosal damage, presenting with diarrhea, mucus, and tenesmus, and you treat it with butyrate enemas. Chronic radiation proctitis, on the other hand, shows up months to years later. The mechanism actually shifts to obliterative endarteritis, causing strictures and severe bleeding that requires endoscopic thermal coagulation. And remember, if radiation isn't in the patient's history, you need to consider STI mimics like gonorrhea, chlamydia, or HSV based on their exposures. Check out how visually distinct rectal prolapse is based on its severity. The mucosal prolapse on the left shows these radial invaginations and is usually managed medically with fiber and pelvic floor exercises. In stark contrast, the full-thickness prolapse on the right displays a circumferential protrusion with really distinct concentric rings of erythematous mass. When a patient has this full-thickness protrusion causing debilitating symptoms like fecal incontinence, surgical intervention is definitely the preferred route.
Let's rapidly contrast two extremely painful conditions.
An anal fissure presents as sharp pain with defecation and bright red blood almost always right at the posterior anal midline. First-line medical therapy is straightforward: stool softeners, sitz baths, and topical vasodilators like nitroglycerin or calcium channel blockers. Now contrast that with an anorectal abscess. Here you've got constant, severe perianal pain, fever, erythema, and a palpable area of fluctuance. Deep abscesses might need a CT scan to confirm, but definitive management requires prompt incision and drainage.
If that exact same patient comes back later with a palpable perirectal tract, chronic discharge, or recurrent perianal abscesses, instantly suspect an anorectal fistula. This is super often linked to Crohn's disease or a previously drained abscess. Because this is a true connection to the intestinal lumen, conservative measures just won't cut it to close it. Definitive management is a surgical fistulotomy.
Section 5. Neonatal GI Emergencies. Okay, picture a neonate, typically under 1 month old, presenting with acute bilious emesis and a distended abdomen. If they're hemodynamically stable, your preferred diagnostic test is an upper GI series. When you see this exact spiral, corkscrew appearance of the duodenum on the contrast study, you've confirmed malrotation with midgut volvulus. So why does this happen? It occurs due to a failure of normal embryonic gut rotation. This leaves the infant with an incredibly narrow mesenteric base, which allows the highly mobile small bowel to just twist completely around the superior mesenteric artery. This completely cuts off the blood supply, rapidly causing gut ischemia and necrosis. To prevent irreversible bowel death, this mandates an immediate emergency laparotomy to perform a LADS procedure. Now, contrast that malrotation corkscrew directly with ileocolic intussusception. When you use an ultrasound to evaluate an infant with suspected intussusception, it reveals this highly distinct target sign or bullseye lesion. It literally shows the bowel actively telescoping into itself. You're going to suspect this in an infant who develops sudden, intermittent abdominal pain, basically pulling their legs right up to their chest. On exam, you might actually palpate a sausage-shaped mass in the right abdomen, and they might pass those classic current jelly stools. Your preferred first-line step here is amazing because it's both diagnostic and therapeutic, an air or saline enema. You only move to a surgical laparotomy if the enema reduction fails or if there are clear-cut signs of peritonitis. Finally, look closely at the highlighted areas on these abdominal x-rays. What you're seeing is pneumatosis intestinalis, which is air actually trapped within the thin bowel wall, along with linear branching portal venous gas up in the liver. These are the absolute hallmarks of necrotizing enterocolitis. The clinical vignette for necrotizing enterocolitis, or NEC, is highly specific. You're looking for a premature infant with a very low birth weight, usually under 1.5 kilograms. The trigger here is almost always the initiation of enteral feeding. Gut mucosal invasion by gas-producing bacteria causes severe inflammation. This leads to rapid feeding intolerance, bilious emesis, bloody stools, and massive abdominal distension. Management must be incredibly swift. Instantly discontinue all enteral feeds, decompress the bowel with a nasogastric tube, and start aggressive IV fluid repletion. You only advance to surgical intervention if imaging reveals pneumoperitoneum, indicating free air under the diaphragm from a perforation, or if the infant clinically deteriorates despite your maximum medical management. Bowel perforation in necrotizing enterocolitis rapidly progresses to lethal septic shock and disseminated intravascular coagulation. Because of this extreme risk, you absolutely must draw blood cultures and administer empiric broad-spectrum antibiotics immediately. Mastering these specific presentations, recognizing the danger signs, and knowing your exact next best steps is exactly how you will safely triage lower GI emergencies and secure a top score on Step 2 CK.